Melanoma Matters is an educational resource. The content represents our opinions and does not constitute medical advice. If you're a patient with questions specific to your situation, please consult your medical practitioner. My name's Larkin.
And I'm Sapna Patel.
So today we're going to be talking, I think, about our first episode related to neoadjuvant treatment. But before we maybe get into that, Sapna, I think I'm going to ask you, what's the best film you've seen in the last 5 years?
Oh my gosh, 5 years. Who has a memory for that? I'll tell you the last film I saw because I don't watch a whole lot of films. Well, it's the last two. I saw Oppenheimer on the plane back from Dublin. Thought that was fantastic. I mean, really.
Is it better than Barbie?
So the last one in the theater was Barbie last summer. I took our whole clinic team. We all made a date for Barbie, dressed in pink, did it, nurse practitioners, our PAs, our former pharmacist friends. So Barbie in the theater, Oppenheimer on a plane. Those are literally probably the last two movies I've seen. They are pretty charming. They're pretty good to be able to see. Top Gun 2, if you haven't seen, that's pretty good. But I somewhat have a thing for pilots and,
Okay, well, there's a story there, isn't there? Also in Top Gun 2. It's a bit like Top Gun 1, but the beach volleyball scene was a little bit more abbreviated in some ways, but maybe we won't dwell on that. Too much here. Okay, so let's.
I'll see more Glenn Powell in a beach volleyball scene. He's a fellow Texan, Austinite. Yeah.
Oh, really?
Yeah.
I'll need to look that up. Okay, so neoadjuvant treatment in melanoma. So where does the story start, do you think? What's the background?
Well, it probably just starts with why we thought to do it. There was some evidence in some other cancers, and the real biology behind it is if you leave a macroscopic tumor in place, the immune system, we're really thinking about the immune system here. Neoadjuvant therapy probably has its most promising activity with immunotherapy, though it was used in breast cancer with chemotherapy and lung cancer as well. You leave a tumor in place, you educate the immune system to the macroscopic tumor in place before it gets unresectable or out of control, before it starts spreading. The education you get while the tumor is clearly visible is stronger than the education the immune system would get if you removed it and then it was fighting microscopic cancer. So it's a abbreviated course, educating the immune system and then still ideally getting the tumor out. And I say that with a caveat because there's now a move towards, can we eliminate surgery? Can we reduce surgery? What an incredible goal if we can get to a point of reducing that. But for now, or as it started, neoadjuvant therapy was always about maintaining operability, just maybe moving it down the road a little bit while you get a stronger body response.
Yeah, so I guess we are going to mainly be talking about immunotherapy, but maybe just worth saying something about BRAF targeted therapy in melanoma, because I guess if we go back 10, 15 years now, I think the first attempts at neoadjuvant therapy, at least that I can remember, that were published probably were with BRAF targeted therapy. And I guess without dwelling on it too much, what did we take away from that, do you think?
Yeah, well, BRAF targeted therapy was comforting because we know that the responses are so rapid. And we know that 95% of patients have a disease stabilization, if not a clinical benefit. So you weren't going to run into this issue that, it didn't work and somebody lost their ability to have surgery. So BRAF targeted therapy, BRAF MEK therapy was given, for a matter of about 8 weeks, and then patients would go to surgery. Maybe there's a few conclusions here. One is it did work rapidly. And so in these patients with clinically accessible, bulky stage 3, you sometimes got to the point where it became difficult for the surgeons to find that lymph node that was involved. So then this idea of clipping lymph nodes, if you have such a rapid response, melting of a tumor, that became favorable or sort of in fashion, if you will. So BRAF targeted therapy works quickly. You might end up in a sort of difficult knowing where to operate window. Good problem to have. Second thing is when it was randomized against, say, placebo, or maybe I should say it this way, it was randomized. We did a pilot study at MD Anderson where it was randomized against the traditional approach, resect and give adjuvant BRAF/MEK targeted therapy. When you have a randomized trial, often you'll have a data safety monitoring board just to make sure a few things. One, that there's no futility happening, and two, that there's no excessive toxicity or events happening, in an unexpected manner. And the Data Safety Monitoring Board actually shut down that study early because what was pretty clear after, a couple of dozen patients were randomized is that patients who were receiving pre-operative BRAF/MEK, then going to surgery, then post-operative, with a year of follow-up and more, they were not having recurrences. Whereas patients who had bulky stage 3, having surgery and starting BRAF targeted therapy in the adjuvant setting, within a year, many of those patients were already having recurrence. So there was a clear signal that this was going to be, a significant study. It became hard for the DSMB to see why we would continue to randomize patients to the standard approach. So that's all to say, that really felt good. That seemed like there was a signal for targeted therapy. But ultimately, that was just a small single center pilot study. As more of these were done at qualified institutions around the world and then pooled together and looked, neoadjuvant targeted therapy was doing fine, but you were definitely still having recurrences in those patients who got neoadjuvant therapy, even if they had complete eradication of their tumor. So in due time, a couple years, 3 years, these patients were still having some moderately notable recurrence rates, whereas the immunotherapy patients were seeming to have a better tail of the curve, as we often say. And that was even in the absence of complete responses. That really kind of shifted the field, even though that's retrospective, multi-center, like multi-series pooled analysis. It really seemed that immunotherapy was the way to go. And that's in keeping with a lot of our thinking that perhaps immunotherapy gives you immunological memory that continues after you take the drug away. And BRAF targeted therapy may be a little bit like our antibiotic use. It's effective while you're doing it. It can engender resistance, and then, it only works. It doesn't work when you take it away, theoretically. So.
Yeah, I mean I think that's actually quite an interesting point in its own right, and maybe that segues into BRAF targeted adjuvant therapy, which we're not going to talk about now, but it's quite an interesting question actually, because if you've got those patients with no disease whatsoever, I think there are a lot of concerns with many people, including myself, that while you're on that year of adjuvant treatment, you would suppress micrometastatic disease, and then the curves have come back together. And I'm explicitly talking about adjuvant now, not neoadjuvant. Yeah. And that didn't seem to happen. So then there's this kind of interesting question about thresholds, is it stochastic, et cetera, et cetera, et cetera. But we'll maybe save that up for another day. Okay, so that's a bit of background. So maybe the place to start here on this discussion of checkpoint inhibitors is OpACIN-Neo. Do you think? Should we start there?
Yeah, I mean, the foundation of our whole melanoma immunotherapy field is really based off of Christian Blank's work. And, this OpACIN-Neo is one of many studies that he's designed and developed in this area. And it's worth mentioning that if it wasn't for his innovative thinking and his ability to really open these, design these, and then globally, enroll with Australian colleagues, Georgina Long and Richard Scolyer, et cetera, in Australia, we probably wouldn't know as much as rapidly as we do. And then, in the US, we're a little slower, and sometimes our FDA needs a little more confirmation. So we do these randomized trials and go a little slower. But the OpACIN-Neo really built on the foundation work that Christian did called the OpACIN trial. It was a 20-patient pilot study, biomarker driven, basically saying if we give immunotherapy before surgery, do we get an enhanced circulating immune system? That's really the hypothesis of why leaving a tumor in place might be beneficial. So is that happening? And he compared that. So he put 10 patients with this pre-operative regimen of 2 courses of immunotherapy. And then he did surgery, traditional adjuvant approach, and gave post-operative combination immunotherapy. And so the regimens were equivalent, but essentially he's looking to see, if we give it before while the tumor is in place, do you get a bigger immune response in the patient? And you did. The short answer is you did. The patients who got neoadjuvant therapy had a more amplified and a more diverse immune system. They developed new clones from baseline, et cetera, et cetera. Now, our good friend Jeff Weber has asked me before, how do you know that that's an anti-tumor immune system that was circulated and not just heightened immune system against antigens that might have mimicry or whatever? That's a fair point. We don't know that, unless that circulating immune system was co-cultured with an autologous tumor and you looked for cell killing interferon gamma. You probably don't know that that's an enhanced immune system that was produced. But everything else being equal, these patients not getting an infection and having exposure to other things, it's a good hypothesis that it is likely due to, tumor in situ that you got the enhancement of the circulating immune system. So having said that, that was a good start, pilot study, but it didn't tell us anything about the effectiveness of the therapy. Do patients live longer? There are some curves you can look at that, get to that point, but it was a 20 patient study. So as we would say, underpowered. OpACIN-Neo started to say, built on the idea of, well, it's a pretty toxic regimen if we give combination immunotherapy to everybody. Can we find a regimen that's optimal? So the OP and OpACIN. And they looked at the full dose of Ipi/Nivo, as it were, the Checkmate 067 dose that we know so well in metastatic disease, for a couple of doses preoperatively. They inverted those doses and they gave essentially low dose Ipi 1 milligram per kilogram, nivolumab 3 milligrams per kilogram for 2 doses preoperative. And then they did, if I'm not mistaken, a sequential dose. And they really did find, they looked at both toxicity and the rate of pathologic response. And from that, they did essentially a pick the winner design. So again, not powered to necessarily say statistically is one arm better than another, but as you look at toxicity and then you look at pathologic response, it looked like this inverted dose was giving you a nice high pathologic response rate, greater than 50%, and a manageable toxicity rate of about 20%. This became the dose that they've used now in subsequent studies and will probably be the sort of legacy dose for neoadjuvant therapy, if you will.
Yeah, so maybe just a couple of points so we're clear. So we're talking here, let's say in OpACIN-Neo, about people with palpable stage 3 melanoma, lymph node disease. Is this the kind of the whole group here? Is that important or necessary? In other words, if you had some other tumor, let's say in another part of the body, for the sake of discussion or argument, let's say in transit disease, which isn't necessarily lymph nodes, might you see the same thing, or don't we know?
Yeah, there's 2 other forms, right? There's the in-transit disease without nodes. That also ends up as clinical stage 3. You can see it, measure it. Those tend to have a fairly favorable outcome. And so historically in these neoadjuvant trials, the amount of those patients enrolled was either eliminated or limited so that they didn't kind of unfairly bias or sort of inadvertently bias the outcomes. So in-transit disease is another form. They can work with these systemic therapies. They work, as we know, with intralesional therapies. They also just have a good outcome if you resect those, if a surgeon's able to resect those. There's also stage 4 oligometastatic disease, where surgeons are now wielding the scalpel to remove very limited disease in the, say, distant lymph node, soft tissue, liver, lung. I will say in the SWOG study, I was impressed at what was called resectable. There was one patient that had liver, lung, and bone, I think, and they call that resectable. I mean, in many spheres, that would have been metastatic disease. It is metastatic disease. It would have been more than oligometastatic, I think. Anyway, surgeons are certainly capable of removing these different weeds, if you were, in different gardens, but the efficacy of neoadjuvant therapy there, that's already metastatic disease. Would you prefer to use a full dose regimen? I think it's unclear, and not all of these studies had enough of these resectable stage 4 patients. So maybe as an Easter egg, we can put a pin in that and review some of the trials that actually do look at adjuvant, neoadjuvant in resectable stage 4 disease at another time.
Yes. So maybe just another quick word about steroids and CTLA-4 dose, which we talked about a little bit in metastatic disease already. I guess we can be confident that if we're using single agent anti-PD-1, in the neoadjuvant setting, it's given us the kind of lowest amount of toxicity we can expect from any regimen. Then maybe a bit of steroid usage for side effects, probably not that much though. But once you start cranking up your anti-CTLA-4 dose, yes, you may well get more pathologic responses, but at the same time, you're going to get more immunosuppression there to manage side effects, I mean. And so, is there a sweet spot? I mean, is there a trade-off there, or are we just going to have to wait for a long time to find the answer to that, do you think?
It's a big question. I think there will be a sweet spot. I think what we would like is a biomarker to identify people who will do fine with single agent immunotherapy as far as efficacy, and then the biomarker for folks who will need more than that. And then also, as we've said before, a biomarker for toxicity, because a toxicity, if you know somebody's a setup to get some type of toxicity, that may lean you to start with a single agent or rely wholly on a single agent. But perhaps I'll say this this is getting a little bit, this is presuming knowledge to the listener that hopefully you have, but maybe if you're using this as a learning tool, you'll get it in the future. The SWOG S1801 study used single agent PD-1. One patient missed surgery due to toxicity. I think this sweet spot will be found once we start identifying better characteristics of these patients. And what we would like to see is patients who presumably can do fine with single agent, don't need the exposure to combination. They can hold on to that until if they become metastatic. If the goal is to prevent metastatic disease altogether and we're able to do that with neoadjuvant therapy, then of course there would be the patients who need that up front to have the best outcome in the long term.
Yeah, I mean, we're not talking about SWOG 1801 in detail here, but I think the general point is an important one about the risk of missing surgery, if you want to call it that, which is then related to, in some ways at least, to the characteristics of the regimen that you use in the neoadjuvant setting. So I think that's an important general point, actually. So what comes after OpACIN-Neo? What's the next step along the road, do you think?
Yeah, I mean, I think, and we'll talk about it in another episode, is they started to use this optimal regimen to say, okay, what next? Can you do less surgery? Can you do less adjuvant therapy? I think the other thing is that, Christian's group has always had a strong translational hat on when they do these studies. So they give you the clinical endpoints, but then they do a lot of work on the blood and tumor samples. And so the OpACIN-Neo started to get at, are there patients, that are doing favorable with each of these regimens? And it's starting to uncover that spool of, biomarkers in the neoadjuvant setting with immunotherapy that might predict outcome. So this was a really important study. Maybe just for citation purposes, we can say the original was published in the OpACIN-Neo phase 2 randomized trial. It was published in Nature Medicine in 2019. In fact, Nature Medicine's had a call for immunotherapy neoadjuvant papers for some time. It's about to close in June 2024. So probably by the time these podcasts actually hit the air, but we'll probably see a nice tranche of additional papers hitting Nature Medicine before then.
Okay, so maybe there's not too much more to say about OpACIN-Neo other than to say very important study. Christian Blank and colleagues at NKI are really leading on this, and I think it's opened up, lots of doors, not just in melanoma, but I think in lots of different tumor types, and we're really beginning to see the results and the outcomes of that. So thank you very much indeed.
Thanks.